Hello, my name is Haytham Mekawi. Today we are presented with a real and dangerous case from obstetric critical care. A 24-year-old woman, pregnant for the first time, arrives at the emergency department at 38 weeks of pregnancy. She has been vomiting continuously for 3 days, she appears visibly exhausted, and her eyes are clearly yellow. At first sight, this presentation may appear to be a common problem related to late pregnancy. However, within a short period of time, this patient will require mechanical ventilation, massive blood transfusion, and advanced intensive care support. This clinical picture raises a strong suspicion of acute fatty liver of pregnancy. At first glance, this woman does not appear critically unwell. She is awake, responsive, and resting comfortably in her bed, which can easily create a false sense of reassurance. However, beneath this calm appearance, her liver is failing, not because of infection or inflammation, but because the liver cells have lost their ability to generate energy. In acute fatty liver of pregnancy, fat accumulates inside liver cells as countless microscopic droplets, disrupting mitochondrial function and shutting down essential metabolic processes. As glucose production falls, her blood sugar drops, clotting factors are no longer produced adequately, toxins begin to accumulate, and other organs such as the kidney start to suffer. This explains why she develops hypoglycaemia, coagulopathy, and progressive organ dysfunction, despite appearing relatively stable. The true danger of this condition lies in how quietly it progresses, because what looks like stability on the outside may in fact be severe metabolic collapse at the cellular level. Early recognition is therefore critical, as delay does not announce itself dramatically, but advances silently until it becomes life-threatening. During the initial clinical assessment, the patient appears conscious, alert, and oriented, which may falsely suggest stability. Her blood pressure is 140/80, which is not severely elevated and does not immediately point towards severe preeclampsia. There are no seizures, no visual disturbance, and no obvious signs of advanced neurological involvement at presentation. Obstetric examination confirms a single-live fetus encephalic presentation, and at this stage, fetal movements are still perceived by the mother. This relatively reassuring clinical picture is typical in the early phase of acute fatty liver of pregnancy, where profound metabolic and hepatic dysfunction may already be developing, despite the absence of dramatic physical signs. The laboratory findings reveal the true severity of the illness and expose the red flags that must never be ignored. Liver enzymes are clearly elevated, indicating acute hepatic injury, but they are not in the extreme range seen with viral hepatitis, which is an important diagnostic clue. Bilirubin levels are markedly raised, confirming impaired liver function rather than isolated cholestasis. One of the most critical findings is severe hypoglycaemia, which reflects failure of hepatic glucose production and is highly suggestive of acute fatty liver of pregnancy. Coagulation studies demonstrate profound coagulopathy, with a prolonged prothrombin time and elevated international normalized ratio, indicating reduced synthesis of clotting factors. Rising creatinine confirms acute kidney injury, while metabolic acidosis reflects systemic hypoperfusion and mitochondrial dysfunction. Together, these abnormalities represent a pattern of acute liver failure with multi-organ involvement, and this combination should immediately prompt urgent delivery and intensive care management for suspected acute fatty liver pregnancy. At this stage, the focus shifts from suspicion to diagnosis. Acute fatty liver of pregnancy is diagnosed clinically, and one of the most reliable tools we use is the Swansea criteria. These criteria combine clinical features, laboratory abnormalities, and imaging findings to guide diagnosis in unstable pregnant patients. The diagnosis is made when 6 or more criteria are present in the absence of another explanation for liver failure. In this patient, key criteria are clearly met, including persistent vomiting, jaundice, severe hypoglycaemia, coagulopathy, elevated liver enzymes, and acute kidney injury. This structured approach allows clinicians to make a confident diagnosis without waiting for invasive tests, which is critical because any delay in treatment can rapidly worsen both maternal and fetal outcomes. Imaging plays a supportive role in the diagnosis of acute fatty liver of pregnancy, but should never delay definitive management. Ultrasound is the most commonly used first imaging modality and may demonstrate a bright liver echo texture with or without the presence of ascites, although findings can be normal in early disease. Computed tomography may show a low attenuation liver compared with the spleen, reflecting diffuse fatty infiltration, but it is rarely performed in pregnancy due to radiation exposure and limited added diagnostic value. Magnetic resonance imaging is more sensitive for detecting diffuse microvesicular fat and may confirm fatty infiltration when ultrasound findings are inconclusive, but it is not required to establish the diagnosis. Overall, imaging findings are nonspecific and should be interpreted in conjunction with clinical features and laboratory abnormalities, as the diagnosis of acute fatty liver of pregnancy remains primarily clinical. Despite initial supportive care, the patient continues to deteriorate rapidly as the underlying disease process progresses. Labor is induced, but the fetus fails to tolerate labor and develops severe bradycardia, which is a late and ominous sign of fetal compromise. This deterioration occurs because acute fatty liver of pregnancy leads to severe maternal liver failure, hypoglycaemia, metabolic acidosis, and coagulopathy, all of which reduce uteroplacental perfusion. The fetus is at particularly high risk because maternal hypoglycaemia limits fetal energy supply. Acidosis impairs fetal myocardial function, and placental insufficiency reduces oxygen delivery. As a result, fetal hypoxia develops, leading to persistent bradycardia that does not respond to intrauterine resuscitative measures. Instrumental delivery is performed in an emergency setting, but sadly, the baby is delivered without signs of life, highlighting that in acute fatty liver of pregnancy, delay in diagnosis and definitive management is strongly associated with poor fetal outcome. After delivery, the mother develops massive postpartum hemorrhage, which progresses rapidly despite standard medical management. Uterotonic drugs are administered, but the bleeding continues because the underlying problem is not uterine atonia alone, but severe coagulation failure. Balloon tamponade is attempted as a conservative measure, yet it fails to control the hemorrhage due to inadequate clot formation and ongoing diffuse bleeding. ATT this stage, emergency hysterectomy, becomes the only life-saving intervention to control hemorrhage and prevent imminent maternal death. This clinical scenario highlights a crucial teaching point. Acute fatty liver of pregnancy is not merely a liver disorder, but a coagulopathy-driven critical illness in which failure of hepatic clotting factor synthesis leads to catastrophic bleeding and necessitates decisive surgical and intensive care management. The patient is transferred to the intensive care unit because multi-organ failure is now established and requires advanced life support. She is intubated and placed on mechanical ventilation to protect the airway, correct hypoxia, and manage metabolic acidosis. Vasopressor support is initiated to maintain adequate blood pressure and ensure sufficient organ perfusion in the setting of hemorrhage and systemic shock. Massive blood transfusion is required to replace ongoing losses and correct severe coagulopathy with fresh frozen plasma, platelets, cryoprecipitate, and packed red cells forming the cornerstone of hemostatic resuscitation. This phase of care emphasizes that survival in acute fatty liver of pregnancy depends on early admission to intensive care, continuous monitoring, rapid correction of physiological derangements, and coordinated multidisciplinary management. Management and prevention of hepatic encephalopathy in acute fatty liver of pregnancy begins with early recognition and continuous neurological monitoring, as any change in mental status, confusion, agitation, or reduced level of consciousness should immediately raise concern for evolving cerebral dysfunction. Frequent assessment of consciousness, pupillary response, and airway protection is essential, because early intervention can prevent progression to coma and cerebral edema. In patients with moderate to severe encephalopathy, early airway protection with endotracheal intubation is recommended to prevent aspiration and to allow controlled ventilation, as elevated carbon dioxide levels increase cerebral blood flow and can worsen intracranial pressure. Reducing ammonia production and absorption is a central component of management, and lactulose is used to decrease intestinal ammonia by acidifying the colon and promoting ammonia excretion, with careful titration to avoid dehydration or electrolyte imbalance, while rectal administration may be used if enteral therapy is not tolerated. Non-absorbable antibiotics, such as rifaximin, can be added to reduce ammonia, producing gut bacteria in severe or persistent encephalopathy. All precipitating factors must be actively identified and corrected, including hypoglycaemia, electrolyte disturbances, infection, gastrointestinal bleeding, dehydration, renal failure, and exposure to sedative drugs, with particular attention to hypoglycaemia and metabolic acidosis, which are common and dangerous triggers in acute fatty liver of pregnancy. A strict metabolic control is essential, as hypoglycaemia significantly worsens cerebral dysfunction and increases the risk of irreversible brain injury, often requiring continuous glucose infusion, while sodium and potassium levels must be maintained within the normal range to prevent further neurological deterioration. Prevention of cerebral edema is critical in severe cases, and this includes head elevation to 30 degrees, careful fluid management, and precise control of ventilation, with osmotherapy such as mannitol considered if there are signs of raised intracranial pressure under close intensive care monitoring. Sedatives, benzodiazepines, opioids, and all potentially hepatotoxic medications should be avoided or minimized, as they worsen encephalopathy and interfere with accurate neurological assessment. In refractory or severe cases, advanced supportive therapies such as plasma exchange may be used to remove circulating toxins and inflammatory mediators, while providing clotting factors, and renal replacement therapy can assist in ammonia clearance when acute kidney injury is present. Ultimately, prevention and resolution of hepatic encephalopathy depend on definitive treatment of the underlying condition, and in acute fatty liver of pregnancy, prompt delivery of the fetus combined with aggressive intensive care support usually leads to gradual recovery of liver function and resolution of encephalopathy over days to weeks.